Let's get 2 minutes on the clock and your time starts now. Case 2. Sally Heathers, a 45-year-old woman, presents to your clinic with a complaint of intermittent episodes of bilateral hand tremors and muscle stiffness, progressing for 6 months. She describes the tremors as rhythmic shaking of the hands that worsens with stress or when performing tasks requiring fine motor skills, such as writing or buttoning her clothes. The muscle stiffness mainly affects her hands and arms, causing difficulty with movement and occasionally cramping sensations. Sally works as a graphic designer and has noticed a decline in her work performance due to these symptoms. She denies any significant medical history and takes no regular medications. She has no known allergies. She does not smoke or consume alcohol excessively. On examination, you note bilateral hand tremors exacerbated by posture and action, along with cogwheel rigidity in her arms. Her vital signs are within normal limits. Question 2.1. What are possible diagnoses for Sally's presentation? Provide 3 specific differential diagnoses. Alright, time is up. Let's get to some answers here. So there's lots of things that can cause tremor. With this cogwheel rigidity, this kind of storyline here, of course, the big one that we've got to be considering is Parkinson's disease. Now, other things that can cause similar tremors that you would have to consider as a differential would be things like essential tremor. So it can present very, very similar and takes a little bit of digging sometimes to kind of tease the two out, particularly in those very early phases. Some of the more weird and wonderfuls, of course, you would also keep on the radar. Things like Wilson's disease, quite rare, but you'd be certainly checking the eyes for any of those flashing rings, any history of family history of Wilson's disease, like copper deposition, and certainly one of the first things that most people present with is that tremor to the hands. Of course, we've got our more atypical neurological conditions, so things like multiple sclerosis can have these weird and wonderful presentations. There's a wide range of things people with MS can present with, and so any of these kind of abnormal neurological features, always keep it in the back of the mind. And in this age bracket as well, we would have to also consider stroke or cerebrovascular accident as one of the key differentials not to be missed. We also have the kind of less specific diagnoses of dystonia as well. And tied into that as well, we'd also consider things like cerebellar tremor, and we certainly have a little of that component of intention contributing here. Again, coming into the more weird and wonderfuls, chronic inflammatory demyelinating polyneuropathy, or CIDP. We are starting to get, I think, a little bit more awareness of that and probably getting better at picking it up in earlier phases. Certainly the sooner we do pick up on that, the sooner we can commence things like IVIG and actually stop that process or slow down that process in its tracks. Some of our more garden variety things, of course, common things turn out to be common as it seems, hypothyroidism. And I've actually had a few patients myself that have had kind of this tremor and excitability, a little bit of hyperreflexia, and sure enough, turned out to be hypothyroidism. There's always that catch-all as well of metabolic disorders. You're not going to be getting as many marks for that, but certainly a lot of metabolic derangement can result in abnormal features like this, and of course, I think you would get a mark for it. Coming into the chat here, we have essential tremor, alcohol use, and yeah, I think alcohol use will probably get tied into the metabolic disorders in terms of deranged liver function. It's the elevated urea and things that accumulate and cause that. There's probably not as many other features there that would have you consider it, and they've kind of pushed you away from that by specifying that Sally does not consume alcohol excessively. but I think would be one of those things you would have to consider. And of course, multiple sclerosis, as you've got there. Jenna, you've got Parkinson's disease, multiple sclerosis, hypothyroidism. Fantastic. So well done to the both of you. Of course, more questions, more fun. Let's get 2 minutes on the clock and your time starts now. Question 2.2. Sally's worried as she recalls a grandparent who had Parkinson's disease, and she wants to know if this could be the same thing. What is the criteria for diagnosing Parkinsonism? List 3 specific diagnostic criteria. All right, time is up. Let's get to some answers here. So this one comes from the International Parkinson and Movement Disorder Society, which is a group that meet up of experts in this field to try and get some consistency behind it. Now, you'll note here I've specifically used Parkinsonism rather than Parkinson's disease because they tend to start off with that before to kind of lock in, hey, what could be going on here before then considering things like referral for definitive diagnosis. So the specific criteria is, the defining feature is bradykinesia with at least one of the following. So muscle rigidity, that 4 to 6 hertz, classic 4 to 6 hertz rest tremor, and or postural instability not caused by other conditions. And if you go to the actual diagnostic criteria, there's a whole heap of conditions listed there. And so I think for an exam like this, just specifying not caused by other conditions, I think you're going to be kind of catching all from that. So it's the bradykinesia plus one of the others. This is one of those things that I think we do well in clinical practice, but we don't necessarily use specific criteria. It's one of those walks like a duck, quacks like a duck. It's probably a duck kind of things, but is fair game definitely for an exam condition. So here from the chat, we've got one motor symptom, one non-motor symptom improves with Matapar. You've got it right there in terms of the motor symptoms, the bradykinesia definitely. You could count that rigidity or cogwheeling. But I hate to say, not quite the criteria we're looking for. Again, it's all those things we do look for in clinical practice. Jenna, here we've got the cogwheel rigidity and bradykinesia. Fantastic, and you would certainly get the bradykinesia. The cogwheel rigidity, I think you would get marks there for the muscular rigidity. So look, for a guess, you've done fantastic. And of course, we have here bradykinesia, resting tremors, and rigidity. Fantastic, very well done there. Very happy to see. Of course, more questions. So let's get 2 minutes on the clock, and your time starts now. Question 2.3. You review her presentation and diagnostic criteria and decide she meets the criteria for Parkinsonism. What initial management is appropriate? List 4 initial management actions. Doses are not required. All right, time is up, and let's have a look at the answers here. So we've got two main options that we use in Australia. It is commence levodopa with benserazide or commence levodopa with carbidopa. I think if you're doing one of those two things, you're going to be getting excellent marks there. Of course, you wouldn't be doing both of those things because they're essentially the same thing, just working in slightly different ways, and so it'd be one or the other. In terms of dosing, you're not required to know dosing, but for your clinical knowledge in day-to-day practice, it's actually quite easy because they're both just 50 plus 12.5 milligrams orally, 3 times daily, increasing to 100 plus 25 milligrams 3 times daily over 1 to 2 weeks as required and or tolerated. Now, quite common, particularly when you start these medications, patients get quite nauseated, and so it's very common to co-prescribe domperidone for nausea management, particularly in those early phases. And so, again, you don't have to know, but 10 milligrams orally 3 times daily is required, not only needed for more than a week. Certainly warning of that nausea, definitely valuable for clinical practice. Now, of course, the next thing we're going to be doing is referral to a neurologist for diagnostic opinion and referral to physiotherapist as well for co-management of those motor symptoms and instigation of an exercise plan. We do know there's a lot of evidence behind benefit for early referral for physiotherapy in this patient cohort. Now, this patient's also 45 years old, pretty young, and so a diagnosis of something like Parkinson's or Parkinsonism is a fairly significant thing. And again, we know those that get linked in for that psychotherapy or psychological support early also do much better long term. And so I think you would definitely be getting marks there for having that put into it. Coming in from the chat, so we do have referral to neurologist for ongoing management of Parkinson's. Fantastic. I think you get full marks there. Commencement of levodopa carbidopa. Fantastic. Referral to local Parkinson's support group. I think that definitely ties into that support aspect. And referral to local balance exercise group. Yeah, fantastic. I think that would tie in again to that physiotherapy kind of program there. So very well done. Metapar trial, very good. Referral to geriatrician for assessment. Now, probably wouldn't be accepted. A lot of geriatricians have age bracket restrictions as to who they will and won't see, and so this would fall more into the domain of a neurologist, and I think you would be probably safer in this setting for a 45-year-old patient to specify neurologist over geriatrician. Don't know if you get the marks there, sorry. But certainly, referral for PD support group, yes, you would get the marks, but avoid the abbreviations. And again, I know I'm being pedantic, I'm sorry, but I really want you to practice doing this as if it's in the exam. Otherwise, you might inadvertently catch yourself doing this on the day as well. And for that, you wouldn't get any marks if you had just referred to support group. Or you might maybe get a half mark tops. Well done overall though, guys.